Hello, my name is Lieutenant Douglas Johnson, and I will be discussing anesthesia for orthopedic surgery. The objectives of this presentation will be to describe important aspects of the preoperative assessment related to orthopedic patients, describe the common complications associated with orthopedic surgery, and to describe anesthetic considerations associated with these complications. Preoperative considerations for orthopedic surgery patients include the age of the patient, the associated comorbidities that they have, the medications they are taking, and diagnostic studies associated with their comorbidities. The age of the patient is associated with common characteristics that we should be aware of. Orthopedic surgeries are frequently performed on elderly and pediatric patients. The elderly population is associated with several comorbid medical conditions, the use of anticoagulation therapy, and renal dysfunction. Although this lecture is not focused on pediatric patients, common characteristics found in pediatric orthopedic patients are congenital deformities, trauma, infections, malignancies, and undiagnosed muscular dystrophies, which can be associated with malignant hyperthermia. In our line of work, trauma is a reality. Working in a combat zone carries with it unique considerations. Remember, there's no reason to fix a bone if you did not have a pulse or a blood pressure, so stabilize the patients before performing orthopedic surgery if possible. The geriatric population is associated with many comorbidities. These include hypertension, coronary artery disease, cerebral and peripheral vascular disease, chronic obstructive pulmonary disease, diabetes, osteoarthritis, and osteoporosis. It is common for these obese populations to have joint replacement surgery. Obesity is associated with hypertension, hyperlipidemia, coronary artery disease, diabetes, and osteoarthritis. Osteoarthritis can involve the cervical spine and should be considered when manipulating the head and neck during intubation. It can also cause some challenges with positioning the patient on the table. A significant comorbidity that is common among the orthopedic surgery patient is rheumatoid arthritis. Rheumatoid arthritis affects all of the synovial joints in the body, but as an anesthesia provider, we are most concerned with the cervical spine, temporomandibular joint, and cricoarytenoid joints. With respect to the cervical spine, it is recommended to obtain flexion and extension lateral radiographs if the patient is receiving long-term steroids or immune therapy to rule out atlantoaxial subluxation. This can cause protrusion of the odontoid process into the foramen magnum, compressing the spinal cord and brainstem. If it is determined that atlantoaxial subluxation is present, you must intubate the patient with inline stabilization using a fiber optic scope. Cricoarytenoid arthritis may present as hoarseness or inspiratory stridor and can lead to airway obstruction after extubation. It is also required to use a smaller size endotracheal tube to intubate these patients. The cardiovascular changes related to rheumatoid arthritis are pericardial thickening, conduction defects, and aortic regurgitation. A cardiology consult with ECG and echocardiogram may be required. Pulmonary changes associated with rheumatoid arthritis include pleural effusions, the formation of pulmonary nodules, and interstitial pulmonary fibrosis. A chest x-ray prior to surgery is recommended. Hematologically, rheumatoid arthritis can cause anemia and platelet dysfunction. This can be determined with a CBC and a coagulation panel. Rheumatoid arthritis patients are routinely on steroids for disease management, and this can cause adrenal insufficiency. Common medications that orthopedic patients are prescribed preoperatively are systemic steroids, opioids and NSAIDs for pain control, and immune therapies such as methotrexate. Methotrexate is a leading therapy used for rheumatoid arthritis. It can cause leukopenia, thrombocytopenia, renal toxicity, and hepatic dysfunction. An article written by Gracia, Hill, and Joshi in 2013 discussed the controversial use of stress steroid dosing. It recommended for patients undergoing moderate surgical procedures, which includes joint replacement, that the daily dose of steroid be supplemented with hydrocortisone 50 milligrams IV intraoperatively and 25 milligrams IV every 8 hours for 24 hours. Radiologic studies can include chest and cervical spine x-rays. Cardiac studies include ECGs, echocardiograms, stress tests, and heart cath reports for coronary artery disease and possible stent placements that have been completed in the past. A complete metabolic panel is helpful in determining the renal function and electrolyte imbalances. Coagulation studies are used to determine possible bleeding risks associated with pathology, medications, and immune therapy. Common complications of orthopedic surgery are fat embolism syndrome, thromboembolism, blood loss, and complications with tourniquet and bone cement use. Fat embolism syndrome occurs with long bones and pelvic bones. Fat globules enter the central circulation through tears in the medullary vessels caused by fracture or reaming during surgery. Increased fatty acid levels act on capillary alveolar membranes, releasing vasoactive amines and prostaglandins, resulting in fluid buildup in the interstitial space around the capillary membranes. This can cause acute respiratory distress syndrome. Symptoms of this include agitation, confusion, stupor, hypoxia, and petechiae on the torso and upper extremities. Fat embolism syndrome can lead to thrombocytopenia and increased clotting factors. So intraoperatively, the patient may present with a decrease in oxygen saturation, a decrease in end-tidal CO2, and possibly ST changes. Treatment for fat embolism is primary supportive. Deliver 100% oxygen, provide continuous positive airway pressure, and use vasopressor support as needed to maintain hemodynamic stability. The formation of thromboembolism is highly associated with pelvic and lower extremity surgeries. A study performed by Gudipati et al. Showed an incidence of 1.16% for DVTs and 0.93% for pulmonary embolisms in patients undergoing orthopedic surgery. It also identified hypertension, obesity, and coronary artery disease as risk factors associated with thromboembolism formation. Other factors that may contribute to thromboembolism formation are the use of a pneumatic tourniquet and patient immobility for greater than 4 days. Prevention of thromboembolism is accomplished through the use of pneumatic stockings and anticoagulation therapy. Low molecular weight heparin, warfarin, and low-dose subcutaneous heparin are some of the medications commonly used. The use of neuraxial anesthesia is associated with a reduction in thromboembolism formation. It is suggested that this is accomplished by the sympathetic blockade in the lower extremities. This increases venous flow, decreases platelet activity, and prevents the post-surgical increase in factors 7, 12, and antithrombin 3. I've attached a hyperlink to the current ASRA guidelines for your reference. ASRA provides guidelines for the use of neuraxial anesthesia in patients who are receiving anticoagulation therapy. Pneumatic tourniquets are used by surgeons to create a bloodless surgical field. This can be advantageous but does come with associated risks. Tourniquets create hemodynamic changes when inflated and deflated. Exsanguination of an extremity causes an increase in venous return to the heart. Tourniquets are also associated with thromboembolism due to venous stasis and can cause cardiac arrhythmias related to the washout of metabolic waste and high levels of potassium from the hypoxic limb. Tourniquets are inflated to 100 millimeters of mercury, higher than the patient's systolic blood pressure, and it is recommended that the inflation time not exceed 2 hours. Times greater than this can lead to muscle dysfunction, rhabdomyolysis, and peripheral nerve damage. Patients with diastolic dysfunction may not tolerate increased venous return to the heart. Bilateral tourniquets can increase volumes to a point where patients can go into heart failure. Pain is also a complication of tourniquet use. It begins approximately 1 hour after the tourniquet is inflated and generally is refractory to treatment with opioids. The release of the tourniquet is the only means of relieving tourniquet pain generally. Release of the tourniquet results in a decrease in blood pressure, an increase in heart rate, decrease in body temperature. It increases end-tidal CO2 and minute ventilation in spontaneously breathing patients. And it also causes an increase in serum potassium levels. Blood loss is another complication of orthopedic surgery. The highest incident is with hip and spine surgeries. Ensure that you have adequate venous access for blood transfusions, and this can include large bore IVs and central line access if that's indicated. Blood salvage techniques such as the cell saver may be used to reduce the use of homologous blood products. Polymethyl methacrylate is the cement used to bind prosthetic devices to the patient's bone. Mixing of the components causes the cement to harden and expand. This expansion can lead to intermedullary pressures greater than 500 millimeters of mercury. This increased pressure can cause fat, bone, marrow, air, and cement embolisms to push out of the bone into central circulation. Systemically, the methyl methacrylate causes vasodilation, the release of thromboplastin, and triggers platelet aggregation, leading to microthrombus formations. These microthrombi can migrate to the pulmonary vasculature and cause a pulmonary embolism. The signs and symptoms of bone cement implantation syndrome include hypoxia, hypotension, arrhythmias, pulmonary hypertension, and a decrease in cardiac output. If these symptoms occur, provide 100% oxygen, ensure the patient's fluid status is adequate, and use vasoactive medications to maintain hemodynamic stability. In summary, orthopedic surgeries are commonly performed on elderly, obese, and trauma patients. There are common comorbidities associated with these populations and can have an impact on your anesthetic plan. Some of the complications specific to orthopedic surgery include fat or thromboembolism, bone cement syndrome, blood loss, and special concerns with pneumatic tourniquet use. These are my references. I hope you enjoyed the presentation. Thank you very much.